Hello, everyone. It is Retinopathy of Prematurity Awareness Week, and we have a very special episode today. You'll hear from our parent guest, Tyronza, a little bit later. But first, I have a special guest, Dr. Faizah Bhatti. Welcome, Dr. Bhatti.
Hi, hi. Thank you so much for having me.
Thank you. Share with us a little bit about what brings you here. This is a very special episode for you.
I'm a neonatologist, pediatric trained. My background is pediatrics, and I have fellowship training in neonatology. I take care of babies in the NICU here at Oklahoma Children's Hospital. We are affiliated with the University of Oklahoma and are the um, primary referral academic level 4 neonatal intensive care unit for the state of Oklahoma. Um, I have a passion for eye disease. Have a I work very closely with our pediatric ophthalmologists, and my academic focus, my research focus is on retinopathy. We um, have a research program where we not only study the basic mechanisms of the disease, how does this disease develop in terms of it is an abnormality of blood vessel growth. So we study how blood vessels grow, what causes them to not grow normally, and then we look at the eye disease. We look at that. We look at how do we improve the care for babies with eye disease. So we focus on that research, and then we partner with other centers and institutions around the country, participating in multi-center studies looking at retinopathy as well as clinical trials. Yeah, that's what I do.
Wonderful. So, Dr. Bhatti will be with us throughout this episode, and we'll be popping in and out, providing some medical information to everybody listening. Okay. So, our first question is, what is retinopathy of prematurity?
Yeah. As we know, babies who are born early, there is lack of development of every organ in their body depending on how early they are born. Um, some organs, when they develop, have a good blood supply in them. Um, the blood vessels which supply the retina, which is the very back of the eye. So if we think about the eye, we know and we can see the front of the eye where you see the colored part, which is the iris, the center of the eye, which is the pupil, and the pupil is what allows light to travel back into the very back of the eye, which is the retina. The job of the retina is to take all of those light signals, which we are seeing, and to convert them into electrical signals, which then get translated by our brain. So depending on what the light brings to the back of the eye, the retina is responsible for basically coding that information into electrical signals. And it does that only if it has a good blood supply there. And so let's say a baby is born at 23 or 24 weeks. The back of the eye, actually, the retina surface, has almost no blood vessels on it. The blood vessels don't develop completely until about after 9 months complete pregnancy. It's only at about 9 months that the blood vessels completely cover the surface of the retina. So if you start going backwards, there's less blood vessels there. And if there's less blood vessels, obviously the parts of the retina, which are supposed to develop to allow all of that normal function to happen, won't develop. The problem is that if a baby is born early, the disease occurs in two stages. So the first stage is the blood vessels stop developing. That is because the oxygen which a baby gets in the outside world compared to inside in the uterus is very development. It's much higher. And so that higher amount of oxygen actually signals the blood vessels to stop growing. The factors which allow blood vessels to grow, they stop. But then in the second stage, after several weeks of the baby being in an incubator, maybe getting oxygen, maybe getting a ventilator support, After several weeks, the blood vessels will start growing, but unfortunately, they start growing in a very abnormal way. They're not growing in the beautiful pattern that they're supposed to grow in the normal way to cover the back of the eyes. They instead start to form these little webs and tangles. And these little webs, I call them little spider webs. These spider webs actually start to grow on the surface of the retina. And if it goes unchecked, can actually start to grow into the center of the eye, which is where the vitreous is. It's the jelly-like substance between the front of the eye and the back of the eye. And those blood vessels, if they continue to grow, will actually start to pull the retina away from the back of the eye. And that ultimately, if in its most severe form, which thankfully we don't see that much anymore, but in its most severe form, can then lead to actual retinal detachment. So depending on where that's happening on the eye is a different risk for the different problems which can happen with vision.
So you had mentioned 23 or 24 weeks. W What puts a baby at risk of developing retinopathy of prematurity?
Yeah, that's a good question. So the two main risks are the earlier a baby is born and the lower their birth weight is. Those have always been considered the classic risk factors for ROP. Um, Babies who are born at 23, 24 weeks, most babies will have some form of ROP. Usually it's mild though. However, we know the things that increase the risk of more severe disease will be if a baby needs to be on higher amounts of oxygen for longer periods of time, if a baby is having more drops in their oxygen levels, so the desaturations which can happen, which any parent who's been at the bedside for long periods of time, the alarm going off on the monitor, you look up and the
All the
oxygen
time.
saturation is dropping down. The more desaturations a baby has, the longer the desaturations, the more oxygen they need, the greater the risk. If a baby has multiple bouts of infection, if they get sepsis, if they get things like necrotizing enterocolitis, the gut disease, all of these stressors which a baby can have early on, the more of them they stack up cumulatively can increase the risk not only of getting ROP, but if you have a baby has ROP, it can lead to more severe disease.
So knowing that a lot of our premature babies battle these things that you just mentioned, what's the incidence rate of converting or developing a disease? How many of our babies really are gonna see?
Yeah, so it depends on the gestational age at which a baby is born. However, in general, it's somewhere between 45 to 70%, um, depending on the study you look at, the patient population. We are what's called a level 4 center and a referral center. So babies who need treatment generally get referred to us. So we tend to see higher rates of ROP. We're also a level 4 NICU, so we take care of the sickest babies. So level 4 NICUs will generally see babies with higher incidence, so closer to the 65, 60% range. However, thankfully, only about 3 to 5% of babies will develop disease that is severe enough to need some form of treatment. So, meaning most babies that get ROP, the ROP will spontaneously, will on its own go away. That doesn't mean they're in the clear, but the most severe form of disease will go away. So, thankfully, only a few of those babies will actually get to the point where they need treatment.
We heard from Tyronza about Alicia, or we will hear about her, having the most severe, type of retinopathy of prematurity. And you had also mentioned earlier that there's different forms of it, if you will. Can you tell us a little bit about the different stages?
Yeah. So this is, I think, one of the things that's very important for parents to understand. So there's two things that we look at when we look at the kind of disease a baby has. First of all, is the location of where those spider webs or tangles, we call them. uh, the simple way to think of them is spider webs, but we call them neovascular tufts. And that's the term that parents will likely hear in the NICU is the ROP will show up as a neovascular tuft. So when they look at the tufts, number one is the location. And the location is important because there's a part on the retina which is the most sensitive for where we have the cells which actually convert those light signals, the rods and cones, they're the most dense, and that's in an area called the macula, which is very close to the very back of the eye. It's not at the very center, but at the very back. Um, so the closer the disease is to that area, to the macula, the greater the likelihood is of losing vision, the greater the risk is. So, first of all, we look at zones. So that's the first term a parent is going to hear is what is the zone of the disease? And the zones are divided in three. So the first zone is that which is closest to the center of the eye. Then you have a second zone, which is a circle around it. And the third zone, which is the area most at the outer ridge of the retina or the periphery, is what we call that. So that's the zone. The second is what we call staging. Staging is how big is that tuft? So if it's a very, very small tuft that barely forms a bump on the surface of the retina, that will be stage one. If it's a bigger tuft that you can actually now see in 3 dimensions, that'll be stage two. Stage three is where it's now become a pretty sizable tuft, and you may start to see blood vessels growing off of the surface. And then stage four is where those blood vessels are actually now starting to grow into the center of the eye. And stage five is unfortunately where now you see that detachment has occurred. So parents are going to hear zone, they're going to hear stage, and there's a third term that they might hear now, which is called plus or no plus disease. Plus disease is something which we've recognized probably more recently in the last decade or so. And that is not only is the tuft significant for the disease, but the blood vessels that don't have tufts may not look normal and they may look dilated or engorged. They may look like they don't have enough structure around them or enough uh, they may seem what's called more tortuous or more kind of like, they have a zigzaggy like pattern. So the greater the disease in that way is, that's called having plus disease. And of course, if the plus disease is closer to that area in the around the macula, so in zone one, that's more significant. So they're going to hear zone, they're going to hear stage, and then they're going to hear plus, pre plus, or no plus. So those are the terms that we use to define the degree of the disease.
What's the process of evaluating and monitoring babies for ROP?
Yeah. So the American Academy of Pediatrics and the American Academy of Ophthalmology have actually put out very comprehensive guidelines, which guide us, neonatologists as well as pediatric ophthalmologists, on when we start the exams for babies. And that depends on how early a baby is born. But in general, the first eye exam is going to be somewhere around 4 weeks after a baby is born. So if they're born at 24 weeks, it'll be at about 30 weeks. Um, but we don't do it earlier than that because you just unfortunately can't get a good look into the back of the eye. There's too much haziness there to be able to see. But that is when those eye exams are going to start. And then depending on the one other zone or stage of disease, it's not really a stage of disease, but one other term that parents might hear is immaturity. And when they hear that, when they hear, well, the or the degree of disease, they'll just hear is immature. That means that simply there's no ROP, but the blood vessels have not yet reached a point of development where they've reached the absolute outer rim of the retina. So we're monitoring not only is there disease occurring, but are the blood vessels growing up to that outer periphery area? And so if it's immature, that simply means that the eyes have not developed. So the eye exams will happen every 1 to 2 weeks, depending on how mature the retina is, the blood vessels, or if the ophthalmologist sees some disease and they want to keep a closer eye on it, the eye exams might happen more frequently.
Um, Once we've started to have the evaluation process, and it's determined that a baby would need a treatment, what do those treatments look like?
Yeah, so we've come some ways in the treatment options that are available. Thankfully, complete detachments are now fairly rare. They do not happen as commonly. Some centers have don't see them at all anymore. They do still happen though, unfortunately, which, if it does happen, requires surgical treatment to be able to try to keep the retina from completely detaching all the way around. Unfortunately, though, the risk of visual loss is still pretty high in that. For stages of disease which are not that severe, we have two primary options. The first is the gold standard, which is laser treatment. And what laser treatment is it's basically a treatment that is delivered. It can be done either in the NICU or we go to the operating room, depending on the center. But a laser wave is given, and that basically addresses the tuft and tries to basically make it go away. It basically tries to burn it and to keep it from growing any bigger or any further. And depending on how many tufts there are, there may be not one laser burn, it's usually more than that. But the ophthalmologist will go in and they will treat all of the areas that either have the disease or at risk of getting the disease. The second treatment is with actually giving medication directly into the eye. And those medications target the growth factors which cause the blood vessels to form abnormally. They are a form usually of an antibody or something that targets that growth factor, which is called vascular endothelial growth factor, or VEGF. Parents might hear that term. It's an anti-VEGF treatment. And that is given actually as an injection directly into the eye. So, under sedation and anesthesia, you numb the front of the eye, and a very, very tiny needle is inserted into the uh, side of the eye, and it delivers that medication directly in. Some babies may need those treatments once, a few of them may need them more than once. Some may need laser first and then injection. Some may need it the other way around. So it really kind of depends on where the disease is, how severe it is, and overall, what is the condition of the baby? How sick are they in general, to kind of drive which treatment is the better option for them?
So, for a lot of people, the eyes are a squeamish spot for them.
Yes.
And even the eye exam is something that I've seen many parents who have a high level of tolerance for what happens to their baby have to step away, because it's relatively invasive getting into somebody's eye, especially your little baby. You mentioned that there's anesthesia and you mentioned even sedation, obviously for both of these procedures. Does the baby feel anything? Is there any residual pain after?
That's a great question. And that's something we're really striving to try to understand better. What we know is we never want any baby in the NICU to suffer. We do not want to have any procedure that is going to be causing undue stress, undue pain. We do our
Yeah.
level hardest best. You're absolutely right. The eyes, when watching an eye exam being done, even the screening eye exams, it can be distressing for anybody to
Yeah.
watch, even medical care providers. What you're doing is basically, to do an eye exam, you have to have um, uh, an instrument placed which is able to keep the eyelids separated, first of all. And then the ophthalmologist is going to use numbing drops. So we use numbing drops directly on the surface of the eye. We then use a second eye drop, which is used to dilate the eye, meaning the pupil is dilated so that the ophthalmologist can go in and get a really good view with the lens that they use, the glass piece that they use to get that. Some centers use cameras to do that exam. So whether the ophthalmologist is looking directly or that camera is used, we will first and foremost of all babies will get those numbing eye drops, and they get that medication to dilate the eye. We really don't want to try to sedate our babies too hard. We never like to intubate our babies for these procedures, and we've
Yeah.
gotten much better at doing supportive care during this. So, feed a baby, swaddle them really well, give them maybe sugar drops during the procedure. Um, we can sometimes give them a dose of medicine to take the edge off during the exam. Anti-anxiety medicines can be given to them. But we really try to keep the baby as comfortable as we possibly can during these exams, because they sometimes do need to be done frequently.
Yeah.
Once a disease is there and we need to monitor more frequently, it may be once a week or sometimes even more than once a week that we have to do this. So we want our babies to be comfortable during this procedure.
Knowing that there's a lot to understand and to keep track of in you with regards to retinopathy prematurity, which seems to affect a lot of our babies, or at least put a lot of our babies at risk. What do you feel like parents should be advocating for their baby and their baby's care?
Yeah, we want our parents to be partners, essentially. And so we highly encourage our parents to be at the bedside, especially during rounds. When I'm doing rounds with parents, we will usually talk about all the systems that are relevant at that time. And talking about the eye exams, I think, is very important in rounds. And I would say to a parent that if you know an eye exam is coming up, or if you know when it's happened and you don't hear mention of it on rounds, please ask the question. Ask what were the findings, what is the plan, when is the next exam going to be. I think that's a very important question to ask. Um, Understanding the staging and the zones, I mean, very honestly, it's not intuitive, it's not easy. When I'm at the bedside, I will usually try to draw a picture for parents. I know our pediatric ophthalmologists, if they are coming in to talk to the parents, they will usually try to do that to explain exactly what it is that they are seeing. Um, I think it's really important for parents before even eye disease has occurred to ask the right questions about what kind of care are we providing to try to prevent this disease from happening? And that's a difficult um, question to ask and really to know what to do. Obviously, the first few weeks of a baby's life, younger they are, the sicker they are. There's a
Yeah.
lot of procedures happening. There's a lot of things that we are doing to really keep these babies alive. And unfortunately, some of those things that we need to do may increase the risk of eye disease. We know the greater the lung disease is, the more oxygen we have to use. We know that the longer babies need to stay on invasive ventilators, um, the greater the risk of that. But I think it's important for questions to be asked, at least on a daily basis, that prompt that thinking. Okay. Do we need to stay on oxygen for longer? What's the plan? What's the plan for us to try to come off of an invasive ventilator? What's the plan for us to try to wean off of even non-invasive support? If we're on non-invasive ventilator, can we get to CPAP? What's the plan for
Mm.
coming off of the CPAP? Um, Asking those kind of questions, I think, is important. But where I think the most important part that parents are going to play in this is making sure that as we are getting ready for discharge, that we are trying to make sure our babies are scheduled for their post discharge ophthalmology follow up. And
Yes.
so ensuring that they know when those appointments are going to be, ensuring that they know and they understand really what the importance of that is. I know when a baby goes home, especially with a lot of other complex needs, they may need to see the neurologist. They may need to see pediatric surgery, depending on what other procedures have happened. They may need to see neurodevelopmental follow up clinic. They may need to see the pulmonology clinic. There's so many moving parts and pieces that if their baby's eyes have not shown a great degree of ROP, but milder forms, we tend to sometimes it may fall to the back burner. It may fall to
Right.
one of those things which may not be on the forefront. But really, we are now starting to understand that even milder forms of disease can increase the risk of having problems with vision as these infants start to get to school age, as they start to get to their teenage years, young adults. The risk of adult eye disease is much greater. Eye disease is greater. So we want to make sure this does not fall to the wayside. So I think parents need to be very strong advocates for um, making sure as they get to school that their regular eye screenings are being done, that the teachers know, that their physicians know, hey, my baby was in the NICU. My baby had mild stage of ROP. Make sure that their physicians are aware of that so that if any follow ups need to be done, those get done in a timely way. I think that's really where we would like to have our parents be partners in this.
That's really helpful. What about somebody whose baby may have had some, lower stages, but then it resolved?
Well, that's, I think, one of my really strong research questions that we have right now. I think we're only starting to understand that better. What we believe happens is that any abnormal development of blood vessels in the eye, even if it goes away, what we think is that it leaves some form of scar tissue that is there. And so while we may not see those big tufts develop, we may not see disease which needs treatment. However, depending on where those tufts develop at some point, even if it's a small tuft, depending on whether it was close to the macula, close to the optic nerve, the center of the eye, or whether it's further away, those scar points will lead to tension in the way that the eye cup is actually developing. So these babies may get strabismus, amblyopia. They may get decrease in their vision. They may have myopia developing sooner than what another baby might have. But truly, I think it's as they get to that young adult age, really looking at, does their retina start to thin earlier? Do they need follow-up for that? Do they need follow-up for, let's say they are an adult and now they've developed diabetic retinopathy or macular degeneration? Um, those conditions where it's starting to understand now that there may be a greater risk for those adult eye diseases. So really regular follow-up with ophthalmology, I think is key and critical, even if they don't have treatment requiring ROP early in their NICU stage and stays.
Since it is Retinopathy of Prematurity Awareness Week, and you are really active and engaged in research, I'm wondering what might be on the horizon for maybe not families who have experienced it already, or their babies have experienced it already, or the next set, but what's on the horizon for folks to really look forward to in the research and treatments?
Yeah, great question. I think one of the things that we are starting to delve into more is we know that the babies that are at highest risk of developing ROP, but even babies that are born early but a little bit older, there still is a risk of ROP. So we know that if you're born at 30 weeks or less gestation age, that's where the risk is highest. And that's where all the guidelines really focus on. But we also know that even if a baby is born at greater than 30 weeks gestation, while the risk of ROP is lower, it is not zero. And so we're trying to understand that population better to make sure that those babies don't get missed in terms of screening exams. We're trying to understand better, what are the risks for those babies? Do they look a little bit different than what it is for a less than 30 weeker? Um, so we're trying to do those studies. We are actually I participate in a collaborative called the CHNC Collaborative, which is a collaborative of level 4 neonatal intensive care units. And so we have an ROP focus group in that group of approximately 20 of us clinicians that are interested in this eye disease. And so that's one of the areas that we're looking at. The second is we're trying to standardize guidelines. We're trying to standardize guidelines for sedation. You asked the question about pain and do babies feel it? We're trying to standardize the way that babies get sedation, comfort during their eye exams and treatments. So that's a second area that you're going to see coming up. The third is really, how do we prevent this from even happening? Okay. We know that once we see the disease is there already. But what we're trying to get at is earlier prevention. Can we try to identify the babies sooner, which are going to be developing ROP later? We're trying to work on things like, can we find genetic factors? Can we find other factors which we can then early in the course, right after a baby is born, maybe at 23, 24 weeks, predictive markers of which babies are at higher risk. And then, really, in this era of genetics and genomic um, uh, medicine really try to identify and develop personalized medicine and care for those babies which are going to be at higher risk of developing this. And I think you're going to see more medication treatments beyond just laser, which are going to be on the forefront. So it's a very exciting time for this field, in which I think we're now getting the data, and we're starting to really see investigators who are interested and passionate in this work, who are doing some phenomenal work, both on the preventative side, the therapeutic side, but also in trying to understand the disease better. So I think parents have a lot to look forward to.
Dr. Bhatti, thank you so much for your time. I know we would want for everybody who's listening to take this information and go back to your baby's doctor and ask some great questions. Thank you so much.
Thank you. And one last plug I'm going to make for resource for parents. I
Yes,
would highly encourage everybody to check out the Prevent Blindness website. I can provide a link to that.
perfect.
Prevent Blindness is a national organization which is basically partnering with developing resources for education for both care providers but also for parents. They have a lot of great videos on their website in English as well as in Spanish for parents to understand the disease, know better about what the treatment options are, but also for individuals providing care after discharge, with how to do a better job at screening these babies, following these babies. And really getting them plugged in with the resources they need. So they're a great resource. Please check them out.
Wonderful. Thank you so much, Dr. Bhatti.
You're welcome. Thank you. Thank you for having me.
So, to talk about her experience in the NICU and with retinopathy of prematurity, I am here with Tyronza Williams, who is a wife, mother, and high level insurance professional who brings both lived experience and practical perspective to conversations about navigating the NICU. She's the founder of Feel Your Feelings, an emotional wellness platform focused on helping parents acknowledge and process the complex emotions that arise during medically stressful experiences. Through her work, she encourages emotional honesty, self-compassion, and resilience while families care for their infants. She is also the creator of Storytime with Ty, a children's storytelling YouTube channel designed to offer moments of calm and connection during hospital stays. As you can hear, she is, and she was, a very hardworking mama of two when her third daughter, Alicia, was born at just 23 weeks. A 23-weeker's experience is long, and each baby's course is unique. For Alicia, everything was further complicated when she needed extra specially highly specialized care for her eyes, about 5 hours across the state from her home in a completely different hospital system. I'll leave it here and let Tyronza tell her story. Tyronza Williams, welcome to Beyond the Beeps.
Thank you so much, Leah. I appreciate the opportunity. Um, so Alicia, she was born at 23 weeks, 6 days, weighing in at 380 grams, which is equivalent to 13.4 ounces. That's right, not even a pound. Um, we experienced severe preeclampsia, but we made it through. They got us to the hospital. The goal was to keep her in as long as possible. We made it 3 days, went out on a Friday, and she was born that Monday, November 11th, special date. Um, from there, before she was even born, the doctors were letting us know what the road could look like for a 23-weeker. Some even encouraged us to kind of just do the comfort care and let her pass. But my husband and I decided, no, we're going to let her fight. You know, she's fought and won against birth control. And so we're going to let her do her thing and show us what she can do. She experienced an 8-month-long NICU stay. We were at Johns Hopkins for 5 months, and then we were moved down to Miami for the last 3 months. And 2 months of that stay in Miami was strictly for her eyes. Um, it was a Thursday afternoon in April. The ophthalmologist called and said, Mrs. Williams, I'm sorry, but Alicia's retina has detached. And this is coming after she'd already had injections, 2 rounds of injections of Avastin to the eye. And nevertheless, within a few days, they're like, "You're going to Miami." We were loaded up. We were in Miami. That Tuesday after we arrived, Bascom Palmer, their team came in, checked her, and confirmed it was a partial detachment. And she would have to go surgery of vitrectomy is what she had. She had 2 vitrectomies, and they both failed. And so right now she's back to kind of square one with a partial detachment in her left eye. Bascom Palmer, they were very realistic with us in saying that, our goal is to make sure her right eye is in the best shape possible. And they've done that. She's had a few rounds of laser, a few rounds of Avastin injections. She's now wearing glasses, but she's still being seen by Bascom Palmer as well to make sure that the ROP is at bay. Most recently, it kind of flared back up, and we were back in Miami December 9th. She had to have another surgery, some laser to that right eye. And her last visit that we saw in the office was January 2nd. And they told us that there's still a little bit there, but they were going to give her an opportunity to allow her body to resolve the rest of those blood vessels. So we'll follow up in March to kind of see what's going on there.
So let's back up for everybody who's listening. And, the path of a 23-weeker is rocky. Like you talked about in the beginning, they sort of said, let's consider giving her comfort care. You guys, you and your husband decided, no, she's here. She's fighting. We're going to fight with her, right? We're going to follow her lead. Let's let her fight. What was her respiratory journey like? She started on a ventilator, I'm sure. Do you remember much about how much she was receiving oxygen? How much was going on with her for her respiratory?
Absolutely. She, as you mentioned, ventilator, vent. One day we went in and there was, I want to say it was the jet. She was on there's 3 different vents, and she was on all 3 at different points of times. They tried to wean her from one, didn't like it. The vent they tried to wean her to was the one that was more realistic, like breaths, versus the shallow vibrating, let's break up this stuff in your chest.
Yeah.
She didn't respond well. And so they had to quickly change her back to the initial. I believe it was the oscillator.
Yeah, the one that vibrates a little bit.
Yeah.
She kind of shakes. Yeah.
Mm-hmm. She was on that for a while. And then they were able to wean her, but she did have to have nitric oxide to wean down to that next lower level vent. To get completely off the vent, she had to do, what is it called, Leah? The steroids. She did 2 weeks of the steroids. And being in those preemie groups, most babies go on to those steroids. She did a 2-week course, and she was able to get off of the steroid, or off of the vent.
Wow.
Of course, from there, she was on the vent about 2 months, though.
2 months. That's what I was going to ask you about, how long she was on that.
About 2 months, and then she went on to the next, the setting.
A little
I believe
CPAP.
it was a CPAP.
Yep.
Yep. It was a CPAP. And she stayed there for some time, and then they were able to take her down again. And then after a while, it was like once they tried to wean her once more to that high flow, they felt she couldn't do it. So she ended up having to have done a bronchoscopy to see if there was anything going on with her airways. And there was a little like mild floppiness there, but nothing of concern. And the team was like, you just got to make her do it. You got to make her do it. And the opportunity never came at Johns Hopkins to make her do it, because in that process, her eye situation happened and we were down in Miami.
Let's talk about that for a second. When do you remember them first looking for retinopathy of prematurity?
37 weeks.
Okay.
37 weeks. And I remember I was that proactive parent always asking, oh, when can she wear clothes? When are we going to do this exam? And so those numbers stuck with me and they told me 37 weeks. And so around 36 weeks, I was, hey, Alicia is going to be 37 weeks. Is she on the list for the eye exams? And they're like, I don't see her, but they made sure they got her on.
Mm-hmm.
When she finally did get checked, she already had stage 1, zone 2. And then the following week, they didn't even let her go a week without being checked.
Right.
And so it kind of stayed at bay. And then the next time it was like, oh no, she's progressed to stage 3. And that was her first time of having the Avastin injections in both eyes.
Okay.
And then the ophthalmologist did tell us, it may or may not work. Laser may be in her future. And all the things ended up being in her future.
Yeah. Let's talk about that a little bit. I mean, so they began the diagnosis that when she was gestationally at 37 weeks, right?
Correct.
And it sort of just kept progressing, which is going the wrong way. And how long was it before they said, we've got to escalate the care. We've got to send you over to Miami?
In terms of her initial assessment of the eyes, or just from them finding out? Okay, the initial. So let's do finding out.
Yeah.
That Wednesday or Thursday, he came in and said the retina's detached. And he said he had to call around to see who could accept her because there aren't many pediatric retina specialists in the United States.
Mm-hmm.
And so he did tell us, Miami is going to be my first option. If not, you'd have to go to Atlanta and Emory. If not Atlanta, then we're talking up north, And so thankfully, Miami was able to get us in because it wasn't just being able to get accepted by a pediatric retina specialist. She had to get accepted into the NICU because she still had needed that NICU care.
Yeah.
So that was
she was still on oxygen, right? Let's paint the picture for folks. She was still on high flow?
She was still on oxygen. No, she was on
a CPAP.
The CPAP. Yep.
Okay.
She was on CPAP still.
So she wasn't eating by mouth.
She was still on NG tube.
Mm-hmm.
And in fact, then they had it was the NJ tube. So they had hers a little further. So all of the things, all of the wires had to come with her. The Miami's NICU Holtz accepted her, and then Bascom Palmer's retina specialist, Dr. Baracall, was like, yeah, we'll do it. Mm-hmm. So from finding out that Thursday to Sunday, we were gone Sunday. We were gone that Sunday. So 3 days. Yep, 3 days. And that in itself, the waiting game, it was a difficult time because it was so much uncertainty. Like, what is ROP? Like, you already know at the 37 weeks, they only tell you a little bit about it, right? Because they don't expect the worst to happen in terms of the retina being detached. Even the ophthalmologist, he was like, we don't know how this happened. To this day. Like, when he sees her in office, he's like, I just don't know. I don't know what happened. I was surprised to see this happen. Even some of the nurses in the NICU, like, they would come down. Hey, I heard what's going on. We've never had that happen. Like, can you tell us what they told you just to kind of enlighten us?
Yeah.
And so,
what did they tell you?
Pretty much her retina had partially detached. And if she didn't get this treated immediately, she could be blind. So it was a matter of urgency.
Yeah.
And so, for us, it was even, I get alarming because the professionals were clueless,
Yeah.
So you have parents who, this is together our 6th child. None of them have been in the NICU. So that in itself was like, okay, what are we doing here? How do we end up here? And then from one extreme to the next, she's stage 4 ROP. And we don't know how she got here. We don't know how it happened. We can't fix it. And now it's just the waiting game to see who's going to accept her in both places as a patient, for the eyes, and
Yeah.
then a patient for in care. And
Right.
so it's just like, whoa. So, we already have our minds turning from that journey in itself, but then our other children at home,
Yeah.
So my husband and I, we've been married for 7 years, and it's just like, we've never been separated like that. And then
Yeah.
our children, I've never been away from them. So it's just so much going on in that time.
So much. And from where you are in your job's Hopkins to Holtz at Miami, on a good day with relatively little traffic, you're talking about 5 hours. It's not a round trip.
Right. And
6 hours maybe.
Hospital to hospital, we'll say, because we live a little over an hour away from Johns Hopkins.
You were
So,
already commuting.
Yep, exactly. So Johns Hopkins to Holt's front door is 3.5, 4 hours.
Okay.
Yeah,
Yeah,
like you
you're not
said,
making
on a
that.
good day, no traffic. Exactly.
Yeah.
Yeah.
So you had a couple of days, which feels like too much and not enough time to prepare to leave where you were living, right? Leave home,
Exactly.
leave your girls, leave your husband. Obviously, that sounds like that meant that you had to separate.
Yes.
You didn't have to separate. You had to live in different places.
Correct.
And because somebody has to take care of the girls who are home,
Yes.
and then you had to come with Alicia.
Yes.
What was that conversation like?
Leah, it wasn't difficult in terms of, like, my husband knew. Some parents will send their child and just stay on the phone with those updates. But my husband knew that was not an option for us. Our baby was going, I was going. It was already difficult leaving her in St. Pete just to come from home to St. Pete, the hour.
Right.
It was hard. There were many days, my children, my older girls had me physically. I was home with them, but my heart, my mind was at the NICU all the time. Sometimes I would just jump up and I'm like, I'm going to see the baby. And my husband had to kind of slow me down, like, I get it, and we still have other children here that need something, but that conversation, it wasn't even really are we going to go? It was more so who's going, because one of us are going to go. One is going. And so my husband was just like, you go because you've been there at the bedside. I tell a lot of people, I think NICU babies or medical complex kids, they're kind of like walking theses or dissertations. And so someone, if not both parents, have to be versed in what's going on, what's happened, what's going on. And if I didn't think that before going to Miami confirmed it. And it wasn't anything on Miami's part or Johns Hopkins' part. It's just the nature of the beast. You have a kid transferring from one hospital to the next. Like you mentioned in the intro, there are different systems. Jackson Memorial uses their own Jackson Memorial app, and Johns Hopkins is MyChart. They don't speak to each other. And then I thought, of course, her documents would have went ahead of her. They didn't. There were times where I stayed, of course, everyone doesn't know, but I stayed in the NICU by my baby's bedside for a month. I didn't go anywhere. If I did, it was just to go upstairs to shower and brush my teeth. And I came back. I would go downstairs and get something to eat, but I was sleeping. I was living at my baby's bedside. And, and so during the rounds, some of the doctors would be like, oh, Mrs. Williams, what happened? And where are we at? And I'm just like, oh, they didn't send it. And they're like, no, we haven't gotten it yet. And so I'm looking on MyChart trying to get the information for them immediately. They still needed it, documentation from the hospital. But if I was able to verbally give them what they needed, that would give them a head start on whatever was going on. And so a lot of times I just felt that I had no option to not be there. I had
Yeah.
no option.
You came with her, and I love that you used that language. She's a thesis, right? She's a dissertation,
Yeah.
and you had to defend it.
Yes.
And
Always.
you were the one who could translate it. You were the one who could explain it. You were the one who could stand up for it. You gave it voice. I mean,
Yes.
that's beautiful. That
Thank you.
I think it is. And I remember those days where you slept in a chair.
Yes.
Holtz is an open bay unit. There
Mhm.
are no private rooms. So you slept in the chair that was
Yeah.
available
Yeah.
every day and night.
Every night.
And I
That's
remember
right.
other parents there, like, worried about you. And nurses said, we've got to help. And I think, where did it make sense to me? I hope I would have been you. I believe I would have been, but nobody can know what you're going to do until you go through it, right?
Absolutely.
So, when you came with her and you started to explain this, you clearly saw how critical a parent is
Yes.
in the NICU. And it was
Definitely.
hyper obvious for that
Yes.
transfer. What were those first few days like to experience?
Initially, so it was rough. It really was. And everyone at Holtz was phenomenal. But as a parent coming from a private bay facility, a private room facility, that was different in itself. And then I also had to remember that the staff at Johns Hopkins was there before she was born, because they were coming up to the room, the mother and baby, or the mother room, to kind of say how things would look. So they already had a little rapport with me and my husband. Um, but I remember when we first got there, I was walking to the back, and the nurse manager that night was like, "Oh no, Mrs. Williams, I need you to wait in the family room while we do all her assessments and everything of the sort." And I'm just like, "What?" Like, I just felt there was a rip from mother baby again, right? Um, but I understood. And so I quietly went, where I needed to go. And then when they finally allowed me to go to her area, I saw her in an incubator. Now, mind you, we left Johns Hopkins. She was in a crib. And so when I saw her in the incubator, it was just like PTSD triggered. And my therapist, when I told her my story, she immediately was like, "Tyronza, I think you have PTSD." And I'm thinking, no way, like, not me. No way. Like, that's something that the service members have and not me. And she was like, "I think you have it." And so I'm like, yeah, whatever. I took it with a grain of salt because she knows her stuff. But it wasn't a rabbit hole that I went down. But when I saw my baby in that incubator, Leah, I was like, no, why is she in this? Like, she can't be in this. She wasn't in this when we came. Like, she's okay. And mind you, when we came or went to Miami, she was still a small baby, but she was a bigger baby in the NICU. And so the nurse, she was very sweet. She was like, "Oh no, mom, we assume the worst, like we assume she can't hold her body temperature, and we assume this and that. And this is why we put her in the incubator, because we don't know her history." And I said, "Okay, I understand." And I did. But I told her my baby was in an open crib. Can we make this happen? And, hindsight, I really made it more about, like, I shift the blame, we'll say, on my baby versus me. But Alicia probably couldn't care less that she was in an incubator or open crib. It was me. Like, it did something to me, because even though she was not in an incubator with all the wires and on the vent, that's what I saw. I saw the pumps that had all the medicine that they were pushing. So I saw all of that. none of it was there. But that's what I saw. That's what I felt. And I'm like, no, this can't happen. It can't be. So I advocated for her to get out of that incubator. And the next morning, her nurse, they switched her out. And I was really grateful for it. But it was those little things, them not knowing who the patient was. And again, I understand because she was a transfer baby and all of the things, right? And that's why a parent needed to be there to advocate, even if it was as small as an incubator situation. But that was, I feel like, just kind of like the tip of the iceberg where the advocating began,
Yeah.
So it was
Yeah, it's
difficult.
communication, right? Like
Yes.
it's from the hospitals communicating to each other. I hear so many opportunities for hospitals to do better around this. They can round on that baby together the day before she transfers. Hello, with Zoom. We have lots of virtual ways of communicating like we are currently right now.
Absolutely.
We could round on Alicia together for days. She didn't come for days.
Yeah.
Also including you in her onboarding to the NICU. I mean, it's something we talk about a lot is parents should be at the bedside for a baby to get admitted to the NICU. They're listening. They should have their mom saying, "It's okay, baby. Mama's here. I've got you." We wouldn't separate a 4-year-old from the parents if we didn't have to, obviously.
Absolutely.
So why do that to her? Yeah, that's heartbreaking. That's heartbreaking. When she, you had mentioned earlier, she had several different types of treatments. She had a statin. She had the lasers. She obviously had you have to remind me the name of the surgery. It's out of my mind now.
The vitrectomy?
Vitrectomy. Yes, thank you. Let's talk about that. So that's something that many families will have had some rounds of a statin or of laser. Hopefully not, but people do. That's a lot more common. But this surgery is very, very rare. Like you've went to 2 hospital systems where it's like the one.
Yeah.
What was that like?
We were hopeful.
Mm-hmm.
We weren't happy about it.
Yeah.
And I'll say this. We were happy that it was an option, but we hated that it was her reality. She'd already went through so many different hurdles in the NICU journey in itself. And then as soon as we turn a corner, we're like, okay, well, maybe she'll soon come home. And then it's the nope, here's the eye. And then there's the vitrectomy, the biggest of the biggest. They told us that they were very honest, and I appreciate it. They were very honest in saying it may or may not work. And they didn't tell us so much about what a vitrectomy was in terms of how they do the procedure. I dare not Google that. I'm a Googler. But that I can only imagine because the retina is in the back of the eye. To get to the back of the eye, what are you doing to get there? I don't want to see if you're using this long needle, or I don't want to see it, So again, the compassion for our daughter was there. Like, you're not even 6-7 pounds and you're having to do things of this altitude, to the magnitude. And it was for a chance. It wasn't promised or confirmed, like, that this will be the fixer of all things. It's just like, we're going to try. And that first surgery, she was back there 5 hours, 5 to 6 hours. And it was very daunting. It was just she and I there. And of course, I'd made friends in my pod. And I would go talk to them or just walk up and down the hospital courtyard until I could get that call of saying, she's done, everything was a success, and now we wait. So after they did the vitrectomy and they returned her to the NICU, she had 2 positions she could be in. She had to either lie on her right side or she could be face down. The only option for her was her right side, because if you put her on her belly, she's going into tummy time position and that wouldn't work.
Right.
Um,
Because she's a big girl now. Remember, it was
that's
37 that she
right.
started the
That's
process.
right.
Like,
That's right.
she's a big
So
girl.
yeah.
She's
So
not a
you
newborn
put her
anymore.
there. Absolutely. So she was trying to roll over and all the things, and it was just a lot. Like, her being on her belly was probably up there with being on her back. She was forbidden to be on the back. That vitrectomy, I believe they put oil in the eye to try to get the retina to reattach itself and smooth itself. Gravity was supposed to help that oil push down the retina, and that was the importance of her staying on either position. It didn't work. It was good. It was looking good for about 3 weeks. And then Dr. Hua, who works closely with Dr. Barakal, came in with her team, and she's like, "Mom, it's starting to lift again." And I'm like, "What do you mean?" She's like, "It's starting to lift again." Because there's nothing else you can say to
Right.
take you have to take the Band-Aid off. And so she said, "We can't go back into this eye right now. So we're going to give her some time, because the eye itself needed to heal before going back in, whether the retina was detaching again or not." So they gave her 5 weeks, I believe, got her scheduled again. And so I want to say it had been 6 weeks between the two surgeries that she went back for the second one. She went back for that second one. It wasn't as long as the first one. I believe she was back there 3 hours that second time. And now the first time she went, she had to get things to both eyes. The vitrectomy in the left eye, and then they did the first round of laser and then more Avastin injections in the right eye. Second time, same thing, but it was just 3 hours. Like, they did a little touch up in the right eye. So, okay, the second time is going to be good. And I remember asking the eye nurse, Annie, of course, I'm like, "Annie, how long or how many times have you seen the surgery have to happen before it's successful?" And she told me she remembered this baby from Puerto Rico. It took 3 times. And so I'm like, 3 times. Okay. So this is still on the second time. It might've been right before that second time, but just kind of prepare myself mentally. Okay. It might take 3 times until it sticks. And so I'm like, okay. Second time, in, out. She did fine. Same thing, back to that right side. And I
And
want
6
to
weeks
say,
older. And
yeah,
with 6 weeks more wanting to play.
yeah. And that's another thing. Like, we don't know if it was just her body not wanting to reattach, or if it's because she's a baby and she's not going to stay in the same spot, But even after that second surgery, they came in 2 weeks, no more than 3 weeks, and said, "Mom, it's lifting again." And so I feel like I'm hit by a Mack truck, like, again. And then not only that, but they tell us this time, our goal was to make sure her right eye was fine. We're not going into her left eye again. So then I'm devastated, and at that point, it was so many feelings. I was devastated from the fact of, okay, our child's eye, her retina is detached. It was a partial attachment, but we're told, of course, that could lead to blindness, being blind. And then I was hurt for the reason of, we've been here at that point almost 3 months, and I kind of felt like, for what? I felt like, why were we here? Now, again, this is just me being real raw emotions. I know hindsight, we were here for an opportunity. It was never guaranteed, but that's just how I was feeling in that moment. And then it was not only for me to hear that, I had to call my husband because, mind you, he's home with our girls. And so I had to tell him, this has happened. So it was like the Band-Aid, snatch, 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 snatch. And they just calmly said, hey, if you want to go back home, you can. We're not going to go back into that eye. And so all the blocks just came down. That was a Tuesday when I remember it was a Tuesday. And I was frustrated and, I cried. Her nurse that day was Nancy. And she acted as her primary while she was there. And I just broke down and I'm just like, I'm done. Done with what? Couldn't tell you. Because
Right.
I'm far from done.
Yeah.
Far
Yeah.
from done.
Yeah.
So in that moment, I'm like, she was like, it's okay. It's okay. And it was, it was okay. It is okay. But I remember leaving. I left the hospital. I said, Nancy, I have to go. So I left. I walked back to Ronald McDonald. And I got ready for Bible study. I got ready for Bible study with the church I grew up in back home.
Mm-hmm.
And I'm like, I can't do anything else. And what point is it to be angry and to kind of use those emotions or energy in a negative light? And don't get me wrong, you feel your feelings, right?
Yeah.
That's what I'm about.
Yeah.
Identify your feelings, you feel them and get, work through it and get over it. Don't let the feelings consume you.
Right.
And so I had my moments. I did. But I just was so confused. Being of big faith, having a big faith background, our community back home, our village, we're all praying for us, for her, and there was a point where I quit praying for my own baby to pray for that family's daughter who was in the Bay with her. I said, Alicia's fine. I knew she had prayer warriors everywhere for her. And so I just didn't understand that even in a moment of the NICU life, me being a selfless person, and still come out with that result in the moment, because a new day came, right? And I'm reminded when I go back into the NICU, her story could be so much worse. Like, regardless of the eye, like just NICU 23-weeker in general.
Right.
It could be worse than what it was.
Right. You had such an incredible, folks who are listening and folks who are watching, you could see it. Like, you are an extraordinary human. Your energy, your presence, your being. What do you attribute that to? Is it these things, your faith? There's something deeper there. What do you think that's all about?
Definitely faith. Life happens.
Yeah.
And I have put it in my mind that everything truly happens for a reason. And we can either cry about it and stay there and, that woe is me, or we can learn the lesson or take whatever we need from that obstacle and keep it moving.
Yeah.
And I choose the latter because not only for myself, but I have children, who look up to me. And so what good is it to kind of be and say, like, yes, this happened, and I'm not going to just sit here and just woe is me. We have to keep moving. Let's pick up the pieces, leave behind what doesn't serve us, and keep moving forward.
Yeah. That's the foundation of feel your feelings, right? Is to feel it.
Absolutely.
And then pick up what you need, leave what you don't.
And keep it moving.
Keep it moving.
Absolutely.
Yeah.
Absolutely. Don't let, you feel your feelings, but don't let them consume you. Because there is times, and this was before, feel your feelings, of course, but specifically the NICU journey, when it started, and this kind of goes back to having to advocate for your child. I remember the first few weeks or so in the NICU, I was numb, um, emotionally, mentally, physically. I was literally like a walking shell. I knew I had to go to this NICU to see my baby, and I went. But there was a moment where I wanted to go no contact with everyone. I kind of felt like, oh, well, if I just kind of be to myself, and I'd rather not deal with anyone else, because you also have to remember, people know you're pregnant. People don't know what has happened in your pregnancy, right? So then there's people, oh, how are you doing? How's the baby? And many don't even know that baby is here. Baby's in the NICU. They don't know. And so you have to have this. You don't have to, but for me, I felt that I had to have these conversations of what has happened, because these are people close to me. It wasn't like, coworkers or anything or anything of the sort, like this family. But I remember feeling like, it'll be better if I could just be to myself in this dark place. And yes, I feel it, but I don't have to tell the world what I'm going through. And it's like God literally sent my dad. He called me and we had a phone conversation. He was like, don't go silent, don't go dark. And it was just so ironic. Like I didn't even tell my husband that I was like feeling that way. So for my dad to call and say, like, don't do it. Don't do it. And so once I started to like open up and tell people what was going on, and, and just be honest, they would ask, well, what does it look like? I don't know. I don't know. But I took notes every day in that NICU. You can kind of see, I was looking back at my notes a few weeks ago. I have 173 pages of notes from Johns Hopkins alone, and then 8 pages in Miami. And you can tell where there was a click between woe is me and let's get to work. You can tell in my notes. It was just like barely nothing to a lot of questions, a lot of notes from rounds. Because in St. Pete, we were always at her rounds until I had to go back to work. But even then, they knew Mom was calling twice a day and she needed a full report.
Yeah. What was when you mentioned going into I love, for me, I feel the same when things are tough. The darkness calls and says, come on down here and lay down, and just sleep with your sadness and your frustration. And reaching back out for me, and I tell folks who I've walked through this experience with, it's an act of selflessness and courage. It is deep, deep love to reach up and out of there.
Yeah.
It feels selfish maybe because it's taking care of you, which is not, especially as a mother who cares for so many people like you do. But it is a true, courageous, and it's a scary act to reach out. What do you remember about what did you do to reach up? I'm imagining you in that hole. What did you do to actually reach up and out of there after you had that call with your dad?
I responded. I'd already had so many people reaching out to me. Like my closest friends, they knew what was going on. And at times I could kind of look back and I was ignoring them. And literally one day, one moment, I decided to respond. And then not only did I respond, I tried to respond with a lie. I'm like, oh, I told one of them, I remember, sorry, I've been busy. Something of the sort, like playing it on being busy, right?
Yeah.
And she called me out. She's like, no, you're not. you're feeling away, and I know, and I understand why. And from there, it gave me permission, not even that you need permission, but it really gave me the permission to really just be honest, be
The
open and
space,
know that,
yeah.
right, to be
Yeah.
vulnerable.
Yeah.
Because of my friends and my circles, I'm usually always the strongest. People come to me naturally for advice. They come to me to vent. Um, and that's the basis of where Feel Your Feelings came from in terms of already having that coaching like mindset. Um, Feel Your Feelings came about 3 years ago. I literally had a dream about it, and so I bought the LLC for it and went from there. Um, but I felt the pull towards it during my NICU stay. But my friend calling me out and saying, "No, you weren't. This is how you're feeling. I can only imagine." It gave me the courage to be honest about it. Everything is not okay. I'm not strong in this moment. Um, but here I am. And it goes back to I'm going to feel how I feel. I'm going to take the pieces that I need to move forward, and I'm going to keep moving forward.
Yeah. Yeah, I mean, the beautiful thing to me that I'm hearing in there is that when she called you out, you let her
Yeah.
in,
Yes.
because you
Yes.
could have, and this is understandable, and we see Pietro, you could have gotten defensive and said,
Yeah.
I'm doubling down on where I am, the way I feel right now. And you said, I'm going to stay open, even though
Yeah.
it's painful. And that, you talked about Band-Aids a lot today. That's a
Yeah.
lot of ripped out hair. And that's
It
what we're
is.
talking about here too.
It
Right?
was. It
She
was.
said, no, I see you. And you stepped into that. And that is really, really deep courage and greatness. What does life look like now for you and Alicia, your husband, and the girls?
Sure. It's definitely a different kind of busy.
Mhm.
In the NICU, we all yearn to go home, and don't get it twisted. We're happy to be home,
Yeah.
but it's still busy.
Yeah.
The NICU, I think, is emotionally busy, especially with me being there. But being home, it is busy. For Alicia, she has occupational therapy. She has physical therapy. She has developmental therapy. She has feeding therapy. She has vision therapy. And this is on top of her doctor's appointments. So it's busy for sure on top of our other children. But we definitely would not trade it for anything in terms of like going backwards. She's making great progress. She's very stubborn and her developmental therapist loves it. And I'm like, why do you love it? She's trying to make her role. She's favoriting one side than the other. As you can imagine, her being down on that right side has done a lot to her developmentally. It's done a lot. So we're trying to counteract that. But she'll roll one way, and her developmental therapist is like, nope, let's go this way. And then Alicia like growls at her, and she'll like try to give her the cues to turn, and Alicia fights it, like, I'm not doing it. If I have to go this way, I'll just lie there. Yeah. And so her therapist, like, she loves it because that lets her know cognitively, because again, I've forgotten, but she had bilateral brain bleeds. She had level 1, and depending on who you ask, at 3 or 4 on the other side. And so to her developmental therapist, it's like cognitively she knows, like, I don't want to do it. I'm not going to do it. You can't make me. I can do it. But usually at the end of her session, she'll do it to show her she can do it. And so
She's like,
she
when
loves
I
it.
want to do it.
Yes, 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 yes.
That's
So
awesome.
it's been great. It has been. It's a different kind of busy. But again, we wouldn't trade it. We know things could be much worse. She's no longer on oxygen. She came home on oxygen. She's no longer on oxygen. We're really just kind of playing the waiting game to see what happens with her eyes. She does wear glasses. But that is the biggest hurdle. She had BPD, so she does breathing treatments, but all of that is literally like a scratch. It's okay. And we know eventually she'll grow out of those things, but it's been a joy.
Wow, Tyronza, we do a couple of things at the end of all of our chats. We're building a virtual NICU knapsack. So from all of our guests, we ask them so for somebody who's listening, you're a new parent to the NICU, what's one thing that you would make sure that that person has in their backpack when they go, or bag when they go to the NICU? Something you
A
couldn't live without.
journal, a
A journal.
journal for sure. If
Yeah.
it's not an actual journal, make sure you have notes on your phone or something, but make sure you have the ability to write down um, how you're feeling, how baby was doing that day, and then any information that was discussed in rounds, whether you were there or not. But that journal is going to be a lot because, again, as I mentioned, the babies are walking dissertations, and
Mm-hmm.
how can you defend your dissertation if you don't remember what last week was like? Because you will have some doctors, and it's not to say it's their fault. Um, but you'll have some doctors and the babies are just a number, and it's kind of like, oh, we'll do A, B, C, and D. But last week, the other doctor, because they rotate, said that you would do X, Y, Z. And so that's when you have to say, wait a second, Doctor so and so said last week, we had this plan, and I would like to proceed with this plan if it's possible. But that's definitely the importance of having that journal. So you've documented what was said from whom. And it's just for your own, it's nothing, no malice behind it, but it's just you want to
Sure.
know who said what so you can advocate for your baby and making sure, let's do this, let's get moving.
Yeah. Well, and that journal allows you to do it because you're the parent. You don't rotate. Like you said, nurses change every 12 hours. Doctors change as well. They rotate through different shifts. So you being able to provide that continuity, it sounds like, I mean, I know you did that from beginning to end and it was life-saving. Okay, so you've shared with us so much. Do you have any other words of wisdom you'd want to share with the family who's possibly at the baby's bedside now?
My wisdom is to be there now, be present, be present. And not only for that dissertation piece,
Mm-hmm.
but to bond with your baby.
Yeah.
It goes back. So many parents have to grieve what their pregnancy was supposed to be or what we assumed it would look like,
Yeah.
that we kind of stay in that grief side so
Oh,
much that we forget to just be present and to still, like, you could still love on your baby no
yeah.
matter where your baby is in the NICU process. If they're 380 grams, then you can't hold them just yet. Still be present, talk to your baby, read to your baby, sing to your baby, do something to still make that connection with your baby. Um, that's what I would say. Definitely be present. And it
Yeah.
goes back, feel what you need, but clock in to where you're at now because your baby needs you.
That's beautiful. And the last question I have for you is what does hope mean to you?
Hope is knowing that there's a possibility for improvement.
Mm-hmm.
And for me, if I looked in the dictionary, Alicia's space would be right there by hope. Given where she's come, what she's overcome, and what she's doing now, she is for sure hope. For
Yeah.
sure.
Yeah. She's extraordinary and
Yes.
just like her mama. Just like her mama. Yeah.
Thank you. And her dad, look,
And her dad. Yeah.
he has held it down so much. He
Yeah.
is truly the backbone of our family because it's been difficult,
Yeah.
for sure.
Yeah.
Difficult.
Yeah, you make a great team, and that is tough in these trying times. So I really appreciate you guys both being able to show up for each other in the different ways, and for the girls, all three girls, and all the kids, and
Yes.
for your community, and for the other families in the NICU, because you did make those strong bonds with other folks, including us here at ICU Baby. And we're just really, really grateful to know you. And I'm so glad that you were here to share about your journey with Alicia in the NICU. Thank you so much, Tyronza.
Thank you so much, Leah, for having me.
Of course. So if you're out there, maybe you're sitting by your baby's bedside listening to us chat, or you're on your way driving in and out of the NICU, maybe pacing the floor at night, sitting by a breast pump, pumping your milk, whatever it might be, you're at work. There's so many ways to be in the NICU. Tyronza and I want you to know that you are not alone, and we look forward to being in your ears again soon. Take gentle care.
Take care.